You are so warmly welcome to this medal education session, and we are really honored to host you this evening. If it is your first time joining us at Medal, we are really passionate about open access, freely accessible medical education. We believe passionately that medical education should be accessible to every colleague everywhere, and we hope you find this session useful wherever you're joining from. It's our honor to host you. Before we begin, it's really important that I share our disclosures with you, and I'm just going to bring those up on the screen just now so that you can see them. And we are really honored to be joined by an amazing speaker who I'll introduce shortly. But if you haven't read what our learning objectives are for this session, I'm just going to bring those up on screen as well. So we intend to help you anticipate emerging therapeutic innovation in cancer cachexia and support appropriate clinical trial engagement. And before we dive into our education, what we normally do here at Medal is ask you some questions about that learning objective before we begin. So I'm just going to bring up some polls, which I would really love you to give us an answer on before we begin. We try to frame our education around clinical cases and clinical problems so that hopefully you can learn something today and take it back to your clinical practice. So we've got a couple of cases that I'm going to share with you. And I would love to know what your answer is on those cases. So the first case is this. A 66-year-old man with a newly diagnosed metastatic pancreatic ductal adenocarcinoma presents with anorexia, 6% weight loss over 3 months, and fatigue. He has measurable disease on CT. He has an ECOG performance status of 1 and a life expectancy estimated at 6 months. He's beginning first-line chemotherapy. According to the design of the ongoing phase 2b/3 pivotal Cachexia and PDAC survival trial of ponsegromab, which statement best describes his eligibility and the trial's co-primary endpoints? If you could give us an answer on that poll, I would be really grateful. I'll give you a little second just to answer that. Thanks for giving us your thoughts. If you're just joining us, we're doing some polls. You'll find them in the chat box on the right-hand side if you're joining on desktop, and using the little chat icon at the bottom of your screen if you're joining on your mobile device. If you're joining on our social channels, you've got to join on Medal next time, and you'll be able to participate in these polls. So we'll give you a few seconds just to share your thoughts about that case, and then we'll dive into our next poll. Okay, the second poll is this. A 72-year-old woman with a newly diagnosed stage 4 non-small cell lung cancer, PD-L1 10%, is started on carboplatin, pemetrexed, and pembrolizumab. She reports progressive anorexia and weight loss despite dietary counseling. Which approach best integrates evolving evidence-based strategies into her care? A, B, C, D, or E? I'm going to give you a few seconds just to look at that poll and to share your thoughts. If you are just joining us, we're doing some polls around some clinical cases around our learning objectives for this evening, and you'll be able to answer them on the right-hand side of your screen. You can scroll up in the chat box if you're on desktop. If you're joining on mobile, you can click the little message icon at the bottom. You can scroll up and you can answer each of the polls. I would be grateful if you could scroll up and give us your answers on those polls. Okay, and then we've got 2 quiz questions for you. So we've done 2 polls. We're going to do 2 quiz questions. The first quiz question is this. Which of the following best describes the role of GDF15 in cancer cachexia? Is it A, B, C, D, or E? And if you can pop an answer on that poll, that'll be great. Super. If you're just joining us, you're really welcome. You're really welcome to this session. We're doing some polls at the moment. They're going to be on your screen in the chat box on the right-hand side. If you're joining on mobile, click the little message icon, and then you'll be able to scroll up and answer all of the polls. You won't miss anything. Okay, and our second quiz question is this one. In the phase 2 randomized study of ponsegromab, which was the primary outcome observed at 12 weeks? A, B, C, D, or E? If you can pop an answer on that poll, that'd be great. And then we'll give you a chance to answer any that you haven't answered yet by scrolling up in the chat box on the right-hand side. They're all still available for you. You can all answer them, even if you're just joining us. Okay, super. Some great responses on there, and everything is going to become clear. We're going to cover each of these questions in our session today. So hopefully, if you don't know the answer, don't worry. All will become clear as we run through our session today. But I'm going to ask one last question, which is this. How confident are you in anticipating emerging therapeutic innovations in cancer cachexia and supporting appropriate clinical trial engagement before we start this education? 1, not confident at all. Up to 5, very confident. If you can share your response, that would be great. This really helps us to hopefully frame our education around patients today, so that we take something home that we can implement into our practice, but also it helps us to continue to improve our education as well. So this is really important. Thank you so much for participating. Okay. Thank you all so much for answering those questions on our poll. So without any further ado, it gives me great pleasure to introduce our speaker today. And I'm really honored to introduce Professor Jeffrey Crawford. And Professor Crawford is the George Barth Geller Professor for Research in Cancer, Professor of Medicine, and a member of the Duke Cancer Institute. And he is going to be sharing with us today on anticipating emerging therapeutic innovation in cancer cachexia and supporting appropriate clinical trial engagement. We're going to have a chance to have questions with Professor Crawford, so please pop any questions you have in the chat box, and we'll have time at the end to have a question and answer session. This is a great opportunity to hear from a world expert, so I'm looking forward to seeing what great questions you have. I'm going to hand straight over to Professor Crawford.
I'm Jeff Crawford, a medical oncologist at Duke University in North Carolina, and I'll be addressing an update in cancer cachexia focused on emerging therapies. If you haven't already seen it, I'd recommend you also listen to Dr. Laird's presentation. It's also on the web with Medall. It focuses more on an overview of cachexia and talks about recognizing the syndrome and how we manage it. Here are my disclosures relevant to today's talk. I'm on the clinical trial steering committee for both Actimed and for Pfizer, and we'll be discussing some of their trials later. Learning objectives are shown here. We'll be talking about GDF15, or growth differentiation factor 15, as a target for potential therapeutic intervention for cancer cachexia. And we'll be doing that in the context of other clinical trials of emerging therapeutic options and the overall treatment strategies that may be applicable to you and your patients currently in patients with cancer cachexia. To start with a case, this was a woman I took care of, a 72-year-old with cough, back pain, poor appetite, and unintentional 10-pound weight loss over 3 months. She presented with fatigue and actually had to close her law practice because of it. She had a past history of smoking, but no other significant comorbid disease. Physical exam was actually unremarkable. Her BMI was actually slightly elevated. Her performance status was clearly impaired at 2. She was mildly anemic, had a low albumin, and workup showed ultimately a stage 4 adenocarcinoma of the lung with a 6-centimeter right upper lobe mass, mediastinal adenopathy, and a 4-centimeter left adrenal mass, all of which were FDG avid on PET scan. Brain MRI was negative. Molecular markers were negative for any targeted approaches, and a PD-L1 score was 10%. So we discussed treatment options with the patient and recommended carboplatin, pemetrexed, and pembrolizumab But we also wanted to refer her to a palliative care specialist. She had a number of symptoms with cough, back pain, poor appetite, weight loss, and fatigue. And actually, by weight loss alone, met criteria for cancer cachexia, which we'll be discussing further. Now, hopefully, most of you are aware of this data. It's now more than a decade old, but Dr. Temmel did an important trial showing that in patients with lung cancer, randomized to early intervention with palliative care versus standard of care with the oncologist, there were multiple improvements in outcome for these patients in terms of quality of life and symptom management. But in addition, there was an improvement in survival. Now, this has not been replicated in every study, but does, I think, highlight the really important aspects of early intervention on symptom management in addition to treating the cancer. Cancer cachexia has been defined in many ways, but the best known definition comes from an international consensus led by Dr. Fearon that described cachexia as a multifactorial syndrome with an ongoing loss of skeletal muscle mass that can't be fully reversed by conventional nutritional support and leads to progressive functional impairment. Now, a decade later, this definition is being revised to take advantage of the fact that fat loss is part of this and quite important, as well as the inflammatory component and the need to address different body compositions globally in other patients. But the Fearon criteria, as we have described them, are that cachexia is defined by a loss of greater than 5% of body weight in 6 months, or if your BMI is less than 20, a loss of greater than 2%. NCCN guidelines are shown here. They're not quite easy to read on this slide, but in essence, because there's not a one standard fits all for how to manage cancer cachexia, NCCN guidelines have recommended a detailed screening for conditions and symptoms that might interfere with food intake. That could be altered taste, could be a dry mouth, could be mucositis, could be depression, could be pain, nausea and vomiting, constipation. That all of these issues really need to be addressed in the context of the patient losing weight. And if that doesn't resolve it, on the right side of the slide, they talk about dietary consultation and potential use of appetite stimulants. And we'll talk a little bit more about that. But it really is a multi-pronged approach that one needs to think about to reverse the weight loss in our patients. In 2020, ASCO convened a group of experts to try to develop management guidelines for cancer cachexia. And you'll see their very first recommendation is actually dietary counseling, which is the best validated approach to improving cancer cachexia. It can't be fully reversed with diet, but it can be ameliorated. They also said that there really wasn't a specific medication that they could recommend routinely for patients, but one could consider either progesterone analogs or corticosteroids as possible options. Subsequently, they added to this list an additional agent shown here, olanzapine. This is a study, a randomized trial in patients with advanced GI and lung cancer. And you can see in red the continued loss of weight on the placebo arm versus weight gain in the group getting olanzapine low dose daily. So different than we would do with nausea and vomiting management, but more longer term. So this is an interesting option. And this is actually being studied right now for those of you in the US that may have access to NCTN trials. This is a randomized phase 3 trial of olanzapine versus megestrol acetate for cancer-associated anorexia being led by Dr. Jatoy at the Mayo Clinic. And we'll address importantly whether there is an actual improvement in anorexia and what the side effect profiles of these two different approaches are may help us help guide future ideas on how to manage our patients. If we look at ASCO and ESMO treatment considerations overall, these are not firm recommendations, but options. One can see they've listed the same agents of megestrol acetate, olanzapine, and corticosteroids. All three of these agents have shown some reversal of weight loss and or improvement in appetite, but none are approved for use for cancer cachexia. And none have shown a quality of life benefit or a functional improvement. And all have some side effects that are potentially significant. So while we have options that we can use for our patients, in addition to tailored approaches that I mentioned from NCCN, we don't have a gold standard of what to do for our patients. So clearly, we have to look to the future, and we have to look to clinical trials to improve outcomes for our patients. One other important approach, and I think very important to incorporate in our practice, is a multimodal intervention. The MENAC trial was reported last year at ASCO in 2024. This is an open label phase 3 multi-center trial that looked at a combination of exercise, nutrition, and an anti-inflammatory medication over a number of weeks in patients with advanced lung or pancreatic cancer. What was seen in this study was that weight was stabilized in patients that got the multimodal intervention versus standard of care, but it wasn't reversed. So patients had less weight loss going forward, but not resurrection or correction of the cachexia. There were no significant difference in muscle mass or physical activity. So again, there's potential benefit, but not what we'd like it to be. This is supported by a couple other phase 2 studies, the Miracle trial done in Korea, and the next TAC2 trial of nutrition exercise done in Japan. And I think all of these tell us the same thing, and that's that we have to take a multimodal approach to our patients' nutrition, exercise, and a tailored involvement of specific agents that may help an individual patient's situation. But we also need to look to the future for better agents. To that end, a clinical trials working group in Cachexia, led by Dr. Barry Laird and Richard Skipworth at the University of Edinburgh, have looked at systematic literature reviews of a number of different endpoints that have been studied in cancer cachexia clinical trials, including physical function, appetite, quality of life, body weight and composition, and biomarkers, to give us sort of a landscape of what the options are and what the outcomes have been. As an example, this is a slide showing the relationship of different measures of body weight and composition compared to the intervention of exercise, multimodal interventions, nutritional interventions, and pharmacologic interventions. One can see the number of studies, the size, whether they were significant or not, but it gives us an idea of what potential endpoints might look like and what the outcomes might be. Of course, that's going to be very dependent on the intervention and whether it's successful or not, but quite important to understand what the different outcomes might be that we think are relevant for our patient population. It's also important to get an idea of the overall landscape of the field. There are a number of agents that have been in development, both preclinically and clinically, that really try to address the central feature of muscle atrophy. And shown here are a number of different approaches by different pathways that may be relevant. We clearly don't have time to talk about all of them, but I'd like to address a few that have been in clinical trials or are in clinical trials as examples of how we might study this area better. One drug is anamorelin. This is a ghrelin receptor agonist. Ghrelin is the hunger hormone. It's actually improved in Japan for the treatment of cancer cachexia. It's the one drug in one country that has this approved. But the development of this has been complicated. If you look at the Romano trials in the middle of the slide, these are randomized placebo-controlled studies done in patients with lung cancer, and there was a clear improvement in weight in these patients. There was also an improvement in anorexia cachexia symptoms, and actual lean body mass or muscle mass improved compared to placebo. But there was no change in a functional endpoint of hand grip strength. And the regulatory agencies in the US and Europe required both things to be met, both functional improvement as well as these other body composition changes. So there was not an approval in the US or Europe for this agent. But in Japan, where they focused more on the symptoms of anorexia and weight gain itself, they were able to achieve approval. And I think that's important, because I think those, even short of function, gaining weight, having a better appetite, is quite important for our patients and for our families taking care of those patients. So hopefully further discussions with regulatory agencies going forward will help guide us on what's really needed for endpoints to get approval of agents. Second drug, or third drug, depending on how we're talking about this, is espindolol. And this is a drug that has anabolic effects to increase protein synthesis through beta-2 mechanisms. It also reduces muscle protein breakdown through a beta-1 blockade, and has 5-HT1A activity that may increase appetite and reduce fatigue. So a number of different central and peripheral effects that may be relevant here in the area of cachexia with this one agent. A phase 2 study has been conducted, and you can see on the right a diagram with the first figure showing the decrease in weight over 4 months for the placebo group compared to 2 doses of espindolol, with the dark blue showing the greatest improvement, which was the high-dose espindolol arm. So the primary endpoint of weight gain was seen in this study. It's a phase 2 study, but it also showed significant improvement in lean body mass and trend towards improvement in fat mass. There was, interestingly, a statistically significant increase in hand grip strength in this phase 2 and trends towards some other improvements. So it's a promising agent with a good safety profile that is going to be studied in phase 3 in global trials, hopefully over the next year. One other agent I'd like to address is the melanocortin-4 receptor. This is the melanocortin-4 receptor neurons are very important for appetite and weight regulation. A number of agonists have been developed to try to impact obesity. But in this study, and this graph that shows sort of a graphical representation of data, TCMC-B07 is an antagonist to melanocortin-4 receptor. So it blocks the receptor. And in animal studies, it's shown you can reverse cachexia by increased food intake, leading to anabolism, increased adipose tissue, and muscle mass. There's also early safety data in the clinic showing no adverse effects for these, or no significant adverse effects for these patients. That's led to an ongoing trial. It's currently active. This is an interesting design. This is looking at newly diagnosed metastatic colorectal cancer patients and randomizing them in a double-blind fashion to daily injection of this melanocortin-4 receptor antagonist or placebo at the very start of chemotherapy for 28 days. The endpoints here are weight, body composition, and BMI, with the goal really of preserving muscle and fat mass relative to placebo. So really focused on preservation and protection of the patient going through chemotherapy. So it'll be interesting to see how this trial evolves. The other thing I want to call your attention to is when we think, well, we've been focused on muscle, clearly muscle is just one component of cachexia. The tumor mediates the changes in a number of cytokines, both from the tumor and the host, and that leads to effects on the brain in terms of anorexia, wasting of fat, the atrophy of muscle we've talked about, insulin resistance in the pancreas, potential dysfunction in the gut, and even cardiac effects. So this is a very complicated situation mediated likely by a number of different cytokines. And as an example of that, this is a study done by Dr. Lerner many years ago, just looking at the association between weight loss and serum levels of cytokines in patients with lung cancer. And you can see a number of different cytokines listed here, which have significant associations with weight loss. So it's likely that there are multiple factors involved in patients. And a number of trials have been done preclinically and clinically to look at blocking one or another of what are mainly inflammatory cytokines. And unfortunately, while there's some impact, none of these studies have been entirely successful in reversing the cachexia phenotype when they've looked at inflammation and inflammatory cytokines. Now, by contrast, GDF15 is not an inflammatory cytokine per se, but a cytokine released by cellular stress. So this exists in low levels in most tissues, increases with aging, and with chronic stress levels are elevated. GDF15, growth differentiation factor 15, signals through the GFRAL receptor in the hindbrain, requires tyrosine kinase receptor RET interaction for signaling, and that leads to downstream effects with impact on appetite when there's binding of GDF15 to the GFRAL receptor. It's influenced by a number of other things on the right-hand side of the slide we'll talk about subsequently. But I think to think about this, Dr. Bright, who's really one of the pioneers of this field, has a nice diagram that I like to show. If you think about acute cell stress. That could be exercise, it could be an infection. GDF15 levels are elevated. That leads to an effective adaptation. One has some component of anorexia and metabolic change. And as that stress resolves, GDF15 levels return to baseline and there's full recovery. In chronic cell stress, such as obesity and diabetes, there may be more prolonged GDF15 elevation and what's an incomplete adaptation. There may still be some benefit to some component of anorexia and metabolic change, but it's incomplete and ongoing. And then we have severe chronic cell stress as seen in cancer, renal failure, and other conditions where there's marked elevation of GDF15. And now we have a maladaptive approach where the loss of appetite leads to weight loss and downstream effects of anorexia, cachexia that we're too familiar with. So to test the importance of GDF15 in this process, it's important to see if we can inhibit it. There are a number of studies of GDF15 inhibition and different approaches that are ongoing, but one is through an anti-GDF15 monoclonal antibody, ponsegromab. Ponsegromab can reduce the active circulating GDF15 concentration and therefore block the signaling that would occur through the GFRAL receptor. The idea being that by blocking that binding, one can reverse the maladaptive effects on appetite, body weight, and the other factors you see there. There are a variety of preclinical studies that support this idea. I'm just showing one here by Dr. Dana Breen. On the right-hand side of the slide, you see healthy mice with no measurable human GDF15 levels, but when injected with a tumor, a human tumor, you can see the GDF15 levels go dramatically higher. On the left-hand side of the slide, we see those same mice injected with a tumor losing weight over time. If you look at the dark blue line at about day 7, mice are injected with an anti-GDF15 monoclonal antibody, and you can see the reversal of weight loss by blocking GDF15. So this is a very important measure, and I think replicated by several other experiments. But ultimately, we performed a small phase 1 proof of principle study. And in this study, patients with advanced cancer getting chemotherapy received subcutaneous administration of ponsegromab every 3 weeks for 12 weeks. You can see on the right-hand side, the baseline levels were elevated, and within 24 hours of injection with ponsegromab, levels returned to undetectable levels of GDF15, and that remained that way until after the study was completed. So suppression of unbound GDF15 in this small study did lead to increase in body weight, improvement in physical activity, improvement in patient-reported symptoms, and a safety profile that was well tolerated. But this was a small study and open label, so it required confirmation, obviously. And this is a randomized placebo-controlled phase 2 study we reported last year at ESMO and subsequently to sarcopenia meetings in Washington. This is also published in the New England Journal of Medicine. Dr. Gork is the first author. In this study, this was a global trial with a primary endpoint at 12 weeks. Patients with non-small cell lung cancer, pancreatic cancer, or colorectal cancer were enrolled. Cachexia, as measured by Ferron criteria, had to be present, and elevated GDF15 levels had to be present as well, which was true for the vast majority of patients. Patients could be on any line of therapy. There was a wide range of performance status that could be enrolled, and the patients were then given either placebo or 1 of 3 doses of ponsegromab, 100, 200, or 400 milligrams sub-Q every 4 weeks. In this particular study, we've mentioned body weight as the primary endpoint, but there are a number of other secondary endpoints that we'll talk about. So for the primary endpoint of body weight, one can see in these different cohorts of patients, treatment policy on the right is similar to intent to treat. On treatment is similar to per protocol. But if you look at the placebo group in gray, you see their continued weight loss on study. versus the 3 doses of ponsegromab, all of which show an improvement in weight, with the highest improvement in the 400 milligram dose of ponsegromab. A subgroup analysis of this 400 milligram cohort is shown here. You can see that regardless of type of cancer, there's an improvement in body weight. Regardless of level of GDF15 in different quartiles, there's an improvement in body weight. Platinum versus non-platinum chemotherapy had similar effects. I will say that although patients given any line of therapy, nearly 90% were on some active therapy during the study. In addition, low BMI patients and higher BMI patients had similar benefit. There was a greater degree of benefit in the most severe group, which is BMI adjusted weight loss category. These are patients with low BMI and high weight loss. There's also similar effects whether patients had signs of inflammation by the CRP, albumin ratio, or the modified Glasgow prognostic score. So it looked like there wasn't a subgroup that did not benefit from treatment, but maybe some variation based on some of these characteristics. For other secondary endpoints, those also were significantly improved. So for patient-reported outcomes of anorexia, there was significant improvement. There was measurements made of non-sedentary physical activity by actigraphy, and that improved non-sedentary activity by nearly about 70 minutes per day. There was also an improvement in muscle index by the lumbar skeletal muscle index measured by CT. So I will call your attention to the fact that in N2, those are the samples that were actually measured. So we're dealing with a relatively small number of patients in each of these cohorts, but clearly it was consistent with the weight change. So the conclusions from this randomized phase 2 are outlined here. The safety profile was similar to placebo. There were AEs, but most of them were due to concurrent systemic anti-cancer therapy. And I think the study does support GDF15, at least as one of the primary drivers of cachexia, an important therapeutic target for further development. Now, this has not escaped the attention of a number of labs and pharmaceutical companies around the world. There are a number of agents that are looking at GDF15 inhibition, different strategies that might be applied. In addition to ponsegromab, relagrotug is an agent that's in development. It's in early phase 1. This is an IV formulation studying a broader range of doses, and that's ongoing currently. It was presented in a trial in progress at ASCO this year. There are 2 agents that are actually developed, at least 2, that are looking at the GFRAL receptor. So rather than inhibiting the ligand, they're directly inhibiting the receptor to see if there's similar or greater benefit to that. And we'll learn more about those studies and hopefully the months ahead. The other strategy that we haven't talked about is whether there's an anti-tumor effect or an anti-immune effect or pro-immune effect of blocking GDF15. And so studies have been done with anti-GDF15 and GFRAL antibodies that are ongoing to look at therapeutic benefit. But to date, the one that's most significant, I would say, thus far, is the studies of visogramab on the right. There's a publication earlier this year in Nature where patients with solid tumors who were immune checkpoint refractory, who progressed on immune checkpoint therapy, received nivolumab plus visogramab, and several patients had a sustained response to the combination, which is interesting and being studied further now in phase 2. So look at this conceptually. We've been talking about cachexia and the impact of increased circulating GDF15 on suppressing appetite. But we know also that GDF15 is immunosuppressive. So elevated levels of GDF15 can block T cell migration into tumors. And perhaps in these patients that got nivolumab and visogramab together, that enhanced T cell infiltration and may be responsible for some of the responses seen. Obviously, a lot more work needs to be done here, but that's an exciting additional area of GDF15 research. But returning to cachexia, our main focus, this is the design for the phase 3 trial, phase 2B and 3 trial that's currently being conducted really globally. And hopefully there's an opportunity for you and your patients to participate in this or some of the other trials I've talked about. But let me just walk you through this conceptually. So this is different than the phase 2 I showed you, and that it's very focused just on frontline therapy and one group of patients, pancreatic cancer. Cachexia has to be met by Ferron criteria. These are patients initiating first-line therapy for metastatic pancreatic cancer with good performance status. So these are all factors I think important to the regulatory agencies to really define the benefit and safety of this agent. A phase 2b is ongoing first to look at different doses of ponsegromab, 200 and 400 milligrams versus placebo. The best dose will then be moved forward to phase 3 in a randomized placebo-controlled fashion. The co-primary endpoints here are change in body weight, just as a prior study, and also change in a patient-reported outcome, the 5-item anorexia symptom scale. Very importantly, secondary endpoints will include physical activity. There'll be some measure to see if there's a functional effect. And the other endpoint is overall survival. We haven't talked a lot about this, but I think we're aware that cachexia is associated with significant shortened survival in our patients. And the question is, if you reverse cachexia, independent of any immune effect, but if you reverse cachexia, will that in and of itself impact overall outcomes in a disease like pancreatic cancer? So this study is actually powered with over 700 patients to be able to address overall survival in addition to the endpoints around appetite and weight. So in conclusion, cancer cachexia is a complex disorder biologically and clinically. Monitoring weight loss in our patients is the best method for early detection and treatment of cancer cachexia. Not waiting till you see the patient look like they have cachexia, but really addressing it at the earlier stages of weight loss is quite important. Our current management is really multimodal, nutritional counseling and support and exercise, and very tailored approach pharmacologically with agents that may reverse individual symptoms for our patients. And I think very, very excitingly, there's improved understanding of our biology of cancer cachexia that's ongoing, but there are a number of promising novel agents in clinical trials now and in the future that will help us address this major unmet medical need. And I hope you'll have an opportunity to participate in some of these studies going forward. Thank you.
Thank you, Prof. Crawford, for an incredible session on some of the latest data and insights in cancer cachexia, and particularly in some of the latest clinical trials. What I'm going to do is I'm going to quickly pull up the QR code for your evaluation for today. If you want to scan that, you will be able to give us some feedback on your session today. And at the end of it, we'll also have some test questions to allow you to claim your CME certificate. We're going to show it again at the end, and I've popped the link into the chat box. But if you're nipping out early, I'd really appreciate it if you could give us some feedback by scanning that QR code. Okay, we have some time with Professor Crawford for questions and answers, and I'm really grateful to have him here alongside me. Prof. Crawford, thank you so much for a really great session. It's brilliant to have you here.
Well, thank you, Phil. I appreciate being here.
We have got some great questions from our audience live with us on Medal today and also across our various channels. I'm going to start with a question which is around GDF15, if that's okay. In your view, is GDF15 the principal driver of cachexia, or is it a master regulator that makes targeting it more effective than addressing the downstream inflammatory mediators like IL-6 or TNF-alpha?
Yeah, I think that's a very important question that I don't really think we have an answer to yet. I think clearly we know that there's so many cytokines involved in patients with cachexia and cancer. And I think we spent a lot of time studying a number of inflammatory cytokines and blocking one or another, maybe having some modest effects on cachexia, but not overall. I think what's different about GDF15 is that it's not an inflammatory cytokine per se, but a stress-related cytokine. So it may or may not go up with inflammation, but it certainly goes up in the case of stress, like heart failure and renal disease and other settings. And clearly, that's what's happening in cachexia with cancer, is that there's a prolonged elevation of this stress cytokine and it becomes sort of maladaptive, as I talked about in the lecture. So it really drives the phenotype we see. So I think we've shown in the phase 2 data, at least, and the preclinical data, that it is a primary driver of cachexia. But that's far from saying it's the only one. It's unlikely it's the only one. I showed data from melanocortin-4 receptor that looks like that has an impact on appetite. It's likely that perhaps some other complex of cytokines will also be proven to be important. So I suspect we'll find several different biologic pathways that are relevant for our patients, but this one right now is leading the way, I think.
And you kind of touched on this in similar vein, but question from Jem, and I'm just bulking these questions together into similar themes. Jem's asking, since anorexia in cachexia is such a maladaptive host response, do you think targeting GDF15 could actually break that cycle?
Yeah, well, I think that's sort of what the data suggests so far. The preclinical data, I just showed you a little of Dr. Breen's work, but a very nice model showing that blocking GDF15, inhibiting it, does reverse appetite. And that restores body weight when appetite's improved, and a lot of the downstream effects happen. I think there's still a question about whether all of the activity of GDF15 is operating through this appetite or whether there are other effects. But it does seem that most of the other effects on muscle and fat regaining is a result of body weight restoration, which is a result of appetite. So I think it's plausible that everything's coming through reversal of the appetite loss that occurs in cachexia. But whether there's some other peripheral effects that we're unaware of, time will tell.
And I'm going to ask you about other effects as well. So good question here. How much of a potential survival benefit do you hypothesize would come from reversing the metabolic aspects of cachexia versus a potential enhancement of response to chemotherapy via immune modulation? For example, could anti-GDF15 therapy become a standard component of immuno-oncology regimens independent of a cachexia diagnosis?
Wow, yeah, I mean, that's exciting, and that's, I guess, a possible future direction. Well, so let's start with just the cachexia without implicating the immune system to start with. We know that cachexia is associated with very poor outcomes for patients. There's very good data showing that just based on body weight and BMI and weight loss, if you look at patients with advanced cancer who have minimal weight loss, high BMI, their survival is much better than patients with advanced weight loss and low BMI. So we know just prognostically it's very important. And there are a lot of studies in individual cancers like lung cancer and colorectal cancer showing that patients with weight loss have poor outcomes. They tolerate chemotherapy less well. Their duration of response is shorter and their survival is shorter. So that's different, though, than saying, okay, if I reverse cachexia, can I restore survival back to the best of the best? And we don't know that yet. The hope would be that could be possible, but no one has really been able to ask that question because we haven't had agents active enough and trials large enough to show that. So to show a survival benefit takes a much bigger study than looking at weight and appetite. And so this trial that I showed at the end that's planned by ponsegromab in pancreatic cancer will be a test of that. Now, if there is a survival benefit, will that be based on cachexia reversal alone, or is there some immune effect? And that certainly could be the case. The pancreatic cancer is not a cancer where we think the immune system is very active. Maybe the nudge that reversal of GDF15 gives might make that a different story. There might also be better delivery of chemotherapy. That could be a factor. So there are several reasons why, if there's a survival benefit of GDF15 inhibition, why that might occur. But that'll be a really great problem to have, sorting out how much is an anti-ectic effect, how much is a immune restoration, how much is better treatment delivery. But that I would welcome the opportunity to look at data that helps support that.
And really interesting question around applying this in a clinical setting. The ponsegromab trials use an elevated GDF15 level as a key inclusion criterion. And that's, I believe, where this question's coming from. Do you foresee GDF15 becoming a routine biomarker for diagnosing and treating cachexia? And should we approach a patient who presents with a classic cachexia symptomatology but has GDF15 levels below the trials? So how should we approach a patient who has classic cachexia symptoms but GDF15 levels below the trials threshold?
Yeah, another great question. So, so one of the really nice things about this agent is it does have there's a biomarker. We know that the ponsegromab and the other anti-GDF15 antibodies are working through inhibition of a GDF15 protein. And so the initial trials, it was important to have a measurement of GDF15 so we could get a dose response and understand what dose was needed to suppress GDF15 effectively. If we gave it to everybody, then maybe we wouldn't be able to adjust the dose correctly. But in those early trials, and particularly the phase 2 study, where we used GDF15 at the same level as phase 1, being greater than 1,500 milligrams per mil, nanograms per mil, there were very few patients that were ineligible based on a level too low. Almost all the patients had elevated levels, and the few patients who didn't reach that 1,500 number, most of them were at 1,000. So almost everybody that meets the other criteria of cancer, weight loss is going to have elevated GDF15. So it's almost universal. So in the long run, I guess we'll have to wait and see how the program develops, whether it becomes an integral biomarker for use, for treatment, or whether the data supports not measuring GDF15 at all, but making any patient meets clinical criteria for cachexia eligible. And I think the phase 3 data will help sort that out.
We've got a few questions here that are quite similar around multimodal approaches. So, and you quite rightly touched on the MENAC trial, which emphasized the importance of a multimodal approach, including nutrition and exercise. Talib is asking, does increasing food intake or giving intravenous nutrition help in overcoming the GDF15 effects? And kind of further to that same question, assuming a potent agent like ponsegromab becomes available, how do you see that integrating with these foundational strategies? Do you see a pharmacological pillar that makes other interventions like physical therapy and nutritional support more effective, or could it potentially even replace them for certain patients?
Yeah, so again, a number of questions bundled there, which is I appreciate. So I get asked a lot about, well, this is all great and these clinical trials are wonderful, but what do I do tomorrow in my practice? Because none of these are available outside of a clinical trial. And that's true. So I do think the data does support a multimodal approach in every patient to address with them nutrition, which clearly has been well documented, not to fully reverse cachexia, but to at least lessen it. So maybe weight can be stabilized, so there's not continuing weight loss, which occurs in the cachexia patients. So nutritional counseling, very important, high calorie, high protein diet, and a nutritionist that can really help work with the patient and family. So that's number one. Exercise, interestingly, there are very few studies of exercise alone. So it's hard to tease out the effect of exercise. And there's no official statement, if you look at ASCO, about incorporating exercise. But almost all the multimodal approaches incorporated, and certainly in other settings, we know that exercise is important. And we also know there's a biologic effect of exercise to increase muscle. So I think even in the absence of large volumes of data, I think those two elements are quite important. And then the question has always been, well, what do you combine that with? Anti-inflammatory agents, some of these stimulants we have, and I don't think we have a right answer to that. And so that's why I guess the wisdom has been to make it personalized to the patient. So if in that long list I showed you of the NCCN symptoms are playing a role of pain or constipation or swallowing difficulties, addressing those in a multimodal approach would be important. And that's what we should be doing now in our practices. And then I'd say making a decision about whether to incorporate an agent like olanzapine or not based on how patients improve. Now, moving forward, I think that while we didn't really control for those things in the phase 2, that is, there was no control for nutrition or exercise in the phase 2 study, and patients gained weight, but that doesn't mean they wouldn't have gained weight more, or the ones that gained weight more may have been the ones that did combine with nutrition exercise. So I'm hoping that the multimodal approach will become even more important when we have active agents approved in the clinic, so that you obviously need to eat and eat well, and eat protein to gain muscle, and you need to exercise to gain muscle. So I think those will still be important components no matter what agents are approved in the future.
I think we're a little bit over time, but we've got one last really great question, so I hope you don't mind us squeezing it in. There's a question really about the applicability of the phase 2b/3 trial for ponsegromab, which is focused on pancreatic cancer, which, while that population has a high burden of cachexia, the condition affects a much broader range of patients, i.e. cachexia. What is your perspective on the potential role of anti-GDF15 therapy in other tumor types or in later lines of therapy where cachexia is often more profound and treatment options are limited?
Yeah, so I covered a lot of ground on this talk. If you remember, the phase 2 included lung cancer, colorectal cancer, and pancreatic cancer across all lines of therapy. So we had patients who were on 3rd and 4th line therapy and people on 1st line. And again, the benefits seem to be present across those lines. So I don't think that the benefits, when they're documented, are going to be different in one group versus the other. I think they may be more substantial in the front line because obviously the earlier, in general in oncology, the earlier you can make an intervention, the better the outcomes are for patients. And certainly I think there'll be programs that look at multiple other cancers and multiple other settings if the pancreatic cancer study is successful, and there will be others that will look as well. I think the strategy is largely around getting from phase 2 to phase 3 and getting drug approved. And that's been the real barrier, as I mentioned, for some other agents in the past. So it's important to have a fairly homogeneous population to be able to measure safety and efficacy. And that's really the reason to make it disease specific at first. But I think we'll see this across lines of therapy if the data I've shown you holds up in subsequent trials.
Professor Crawford, thank you so much for answering so many questions in such a short space of time. Thank you for an amazing educational session. We really appreciate you joining us today.
I've enjoyed it, and thanks for giving me a chance to talk with the audience.
Thank you so much. And thank you to our audience. Thank you for so many amazing questions, and thank you for being so engaged in this topic. And it's great to be able to share those questions with Professor Crawford. I'm going to bring up on screen again just the QR code. If you have joined us today and you would like to claim your CME certificate, you need to scan that QR code. It will ask you for some feedback on the session today, and it will allow you then to claim your CME certificate at the end. It's completely free, and you won't be charged a penny or a cent for claiming that certificate. We have got one final session today that I hope you'll listen to whilst you're completing your CME certificate, and that is from a patient. And we actually had the opportunity to have a conversation with Pamela Dacey, and she is a patient who has experienced cancer cachexia, and she works with Pancreatic Cancer Ireland, and she shared a little bit of her perspective with us, and we're going to hear a little bit from Pamela just now. I'm going to hand over to the interview with Pamela Dacey. I'm really honored to be joined by Pamela Dacey, who is a patient who's experienced pancreatic cancer back in 2018 and has experienced cachexia as part of that journey. And she's here to tell us a little bit about her story. Thank you so much for joining us, Pamela.
No problem. Delighted to be able to help.
Would you be able to tell us a little bit about yourself your journey, maybe a little bit about your connection with Pancreatic Cancer Ireland?
I suppose it began back in the summer of 2018. I wasn't feeling great. I was attending my GP and there was a query of a kidney stone in August or September, but I was experiencing tiredness, which was my only major symptom. And my blood tests were clear, everything was looking good. But I knew coming up to September, October time, things hadn't changed. The fatigue was getting worse. So I attended my GP and said that I needed to be sent somewhere because something wasn't right. So I went for a scan of my kidney in the end of October. And in November, I sat in a consultant's room to be told that the good news is you don't have cancer. And I went, oh my God, I hadn't even thought of cancer. And come December, the first week of December, I was physically exhausted. It was a stage where I'd have to get out of bed, go to work, come home, go back into bed, have an hour's sleep before I could do anything in the evening. And this was like getting worse, debilitating, basically. So I woke up one morning and I looked in the mirror and I thought I looked a bit jaundiced, but I wasn't taking much notice of it. I was just saying, what's the way the light is in the window? So I went to work, came home, and the following day, yes, I noticed I was very yellow. And I attended my GP and they thought that I might have a blocked bile duct. So I got referred to hospital for another scan. And on the 7th of December 2018, I got a diagnosis at 9:15 that night of pancreatic cancer.
It was a lot to take in over a relatively short space of time. When did you first hear, as part of that journey, the term cancer cachexia, and what did it mean to you at the time?
I probably never heard it on my journey. It was afterwards I was trying to figure out what is the term. I kind of liked looking into bits of research and things like that. And I was checking to see muscle wastage, and that's when I came across cachexia. I had heard of sarcopenia in the hospital, different at various stages, but that didn't register with me either. It wasn't until I went searching myself that I found out what I had was cachexia.
Wow. Okay. So you had not heard the term as part of that journey. When
No.
From your perspective, how did cachexia first show up in your journey?
I think I never looked like a cancer patient when I was having my treatment, and I ended up having chemotherapy and radiotherapy, and I still looked like myself in the mirror, bar having no hair, but that didn't bother me. It wasn't until after I had my Whipple surgery, and in the space of, I think it was 7 or 8 weeks, I had lost 7.5 stone, which is massive weight loss. And I was able to put join my hands together and put them around my thigh, and I still had plenty of room left over. I was someone who was always overweight and was paying a tenner every week to be told you're after putting on 4 pounds or 5 pounds and that kind of a way. I'd have been that person. But then I had to go and see a dietitian about trying to put on weight. And I told her straight out the first day, I never in my life expected to be sitting in front of a dietitian to put on weight. But it was severe what I had, the muscle wastage, and sure, it impacted every part of my life.
What were the biggest day-to-day challenges associated with weight loss? Appetite changes or fatigue?
Fatigue and weakness would have been major, because every night I'd make a plan of what I was going to do the following day. My mind was 100% able and willing for everything, but unfortunately my body was probably at 30%. So the plans I'd make the night before never came into fruition the following day. I lost my independence. I needed support to just basically move around the house. I couldn't walk from my bed to my bathroom, which is like ensuite, without having a walking stick or my rollator or somebody beside me walking. It was that constant fear of, if I fell, who was going to help me? How was I going to get back up? No appetite. And then you're at the stage where you're constantly feeling full. You don't feel like you're hungry. So that's a knock-on effect then as well, because I'm looking at food and it's being brought to me to eat it, but there was just no willingness on my behalf to eat what was being given to me.
And do you mind telling us a little bit about what kind of support you received from healthcare professionals when cachexia began to appear?
It was the referral to a dietitian in my community, because the hospitals, I was attending 3 hospitals where I live, and it's about 2-hour drive to the hospital. So they referred me to dietitian in my community. So I had to see that person about trying to put on weight and ways, she gave me a list of things to do, but you're not physically able, you're not going to do them. And there was no follow-up to make sure that I was doing what I was being told to do. So I found a big gap, kind of, when you're going through your treatment, everything is planned out and everything is structured for you. But afterwards, there's nothing in place. And only for I being referred to see them, but I was doing half probably of what I was told to do, because I wasn't physically able, and then I had no motivation to do anything either.
Before even getting to that stage, were there moments that you felt, so you've mentioned that you did a lot of searching about the term cachexia. Were there moments you felt that it could have been recognized or addressed earlier?
Yes, because I had been in hospital quite a few times. Unintended long stays. I was there for 6 weeks at one time, and the dietitian was always coming to see me in the hospital and, trying to give me the drinks, the calorie-laden drinks to put on weight. But I was not a sweet tooth. I had not a sweet tooth before I began this. So those drinks I found were physically so off-putting for me. I said, it was like, because I asked him one day, have you ever tasted them? And he went, no. And I went, well, you should maybe, because it felt like, sugar on a spoon, but a small drop of water. It was that grainy texture I was getting. And I just physically couldn't stomach them. And I was trying to mix them into fruit smoothie. So at least I was, getting some of the goodness in, but I physically could not drink it. As soon as I was drinking it, I was gagging and bringing it straight back up again. That was the only intervention to try and help me with extra calories and do things that way.
And you've kind of hinted at it already in what you were being asked to do in order to kind of improve the situation. From your perspective, what kind of communication from doctors or nurses or other healthcare professionals was most helpful?
I couldn't praise my liaison nurse in the hospital enough. She was fantastic, and I felt she went up above and beyond for me. She used to come out to meet me at the door when I'd be going in with a walking stick, and you have to think, I was in my 40s. I was in the prime of my health before I got this diagnosis, and your independence is taken away from you. I could not do anything by myself, and she used to come out and meet me, walk me in, and tell me that I'm going to have to start introducing calorie-laden foods and stuff again, because I'll end up back in hospital and back being tube fed. And on the threat of my 4th time being tube fed, I was like, right, I have to do something here. And then I came home and I tried to walk a bit further every day, no matter how much it was hurting me, so that at least I was kind of, rebuilding the bit of muscle in my legs again. And I felt each day I'd try and do a few, more steps. That's the only way that I was able to change things myself, because food wise and nutrition wise and sleeping wise and everything else that's involved, there was nothing. It was me trying to move a bit more every day. That was my turning point, I think, myself.
So we've talked a little bit about nutrition. We've talked a little bit about physiotherapy. How valuable is psychological care in managing cachexia?
I think it's very important. I think when you get your diagnosis, I suppose, it's like the oncology team, their focus is just one thing and one thing only, and that's to keep you alive. And there's nothing else goes into the, say, holistic well-being of a patient. So they don't look at the other aspects that are affecting your life, like your age and like where you work, the different things that you would take that I took every day for granted, and then all of a sudden were gone from me. You know, simple things as such, having a meal with your family, which is like a social time and a fun time. I didn't sit at the kitchen table in my house for nearly 2 years. So I missed out on all that interaction, and it's very isolating. But there needs to be some kind of a thing put in place for that the holistic side is looked at, and that the individual is treated as a whole person. And looking at, I think for me, one of the important aspects now is your quality of life after treatment.
Thinking forward, so quality of life after treatment is really important, and we've been talking a lot about ongoing research and what the future might look like in cancer cachexia on this session. If there was a message that you wanted healthcare professionals worldwide to take away about the patient experience of cancer cachexia, what would it be?
I think from my perspective, I suppose cachexia is more than weight loss. It steals strength and dignity. It sees, you know, the person, look at the person, not just the symptoms. And every small act of support, I suppose, helps us hold on to our dignity and our independence.
Pamela, thank you so much for sharing a little bit of your journey with us today. We have these conversations because it grounds us in why we're doing this education, and you've very beautifully brought that back to you know, the most important thing at the end, which is this is about a patient and the whole patient. So thank you so much for that message. Thanks for taking the time to talk to us today. We really appreciate it.
Okay, thanks very much for having me.
I hope that you find that a really powerful message from Pamela, and she did bring it home. She brought it home as to exactly why we're doing this education, which is about a patient at the end of the day. And I hope that that helps you bring perspective to so much of the education that you've learned in this program, in the previous cancer cachexia program, and in all of our oncology and medical content. And we have those interviews because it does bring that context to our education. I hope you find it really useful. I've brought the QR code up on the screen again if you haven't scanned it already. The link is in the chat box, and I will post it there again before you leave. If you want to claim your CME certificate, you can just hit that link and it will take you to the evaluation form. You can scan the QR code, it will take you to the evaluation form. It will automatically award you a CME certificate once you complete that evaluation. It's been a real honor to host you here today. I hope you'll join us at one of our other medal education sessions. They're always free, they're always open access. You can find them all at medaleducation.com. And it has been a real pleasure and honor to host you. Thank you again to Professor Crawford for another incredible session. Have a great rest of your day wherever you're joining us from.